Good morning, everybody. Actually, today I will talking about a challenging case, but not in technique, but maybe challenging in decision making. And I'm waiting to help us me in cases like this to take a decision easy. So, Judy, okay. My first case is male patient, 75 years old, diabetic ischemic heart, history of hernia repair several years ago. Came to us with non-healed ulcer on the right shin of tibia for 8 months, disabling colidication for several years. Actually, we did recommend the CT angio, which showed bilateral, first infrarenal aortic aneurysm, bilateral common iliac aneurysm, right femoral aneurysm, bilateral thrombosed popliteal aneurysm. Here we are. So here, in a case like this, I know how I can fix this actually, but the challenge, you will fix all or step by step, and which you should first start. So my decision was, the patient, by the way, his creatinine is okay, so we think as usual to first in a 75 years old patient, fair general condition, think in endo. So we decided to do endo, branched iliac, repair of common femoral in the same time, and postpone the fembob later on. I don't know is this right or not. So the technique was so straightforward. Insertion of 6 French sheaths, taking angio for the right common iliac to internal iliac. This is the left, passing the wire from the right, then from the left. So insertion of the iliac device. This is snaring the wire, then passing the covered stent, taking angio to show the internal, passing the catheter, and then the covered stent. Finally, taking angio to make sure the right internal iliac is okay, because we decided to occlude the left internal iliac. Deployment. Unfortunately, after deployment was a massive leak, so we should use a balloon and reposition the device a bit. And here we are. This is a completion. It was okay. This is actually some videos to show the technique. Passing the wire from right, then from the left, passing catheter, taking angio to make sure we are in. Here we are. The right common and internal iliac. So thinking in snaring the wire from the right side. Here we are. This is how to use the snare, and pulling the wire to the left side. Right. Then passing the catheter, and then the device, the covered stent from the left side. Deployment the iliac device. Then try to pass the device from the covered stent. Deployment first. Passing the device. Here we are. So this is a straightforward technique for branched iliac. taking angio to make sure we are in the right internal, then passing the wire again. Here we are, passing the catheter. Actually, it was quite difficult because the right internal iliac was very tortuous and angulating, and especially angulating posterior, so it was difficult to pass the wire. Here we are passing the wire and the catheter, and then passing the device, the covered stent. Okay, so after deployment, taking after deployment, we find the covered stent not fully extended, so we have to use a balloon and taking a conventional angio to make sure the right internal iliac is patent. Then continue the procedure from the left side to deploy the main body from the left side, adjustment, the device, deployment, the device, then suprarenal deployment. Unfortunately, another massive leak, type 1 endo leak, so we have to correct it immediately. So we pass a balloon supported by the sheath, ballooning the lower, the infrarenal part and suprarenal part, trying and to push a bit, not hard, upward. If you can succeed to reposition the graft for a few millimeters. Here we are, we dilate the suprarenal. It's okay. Just 1 minute.
Dear doctor, you
Sorry
will tell
about
me
that.
that.
Yeah. Yes, please. Okay. Right, completion angio. Fortunately, there is no leak. We are lucky. Then we did continue the procedure to the end, and we repair the right common iliac. We make an aneurysmography rather than anything else. Patient post-op is okay. Actually, 2 months later, the patient underwent right femoropopliteal bypass vein graft, blue knee, but to be honest, somewhere else. Another colleague done it privately somewhere else. So we don't have it. The reason behind my presentation, actually, a case is like this is a second case. This patient waiting a decision, still not operated upon. He's 55 years old, fit and well, because we just try to remind the nice guideline here. He's fit and well, diabetic, hypertensive, came with left lower limb critical ischemia. He's 55 years old. He actually has a common infrarenal aortic aneurysm, right common iliac aneurysm, left external iliac occlusion, right common femoral aneurysm, patent right popliteal aneurysm, thrombosed left popliteal aneurysm, and they came with a critical limb ischemia for the left lower limb. This patient waiting your discussion and your opinion. So, if this is your patient, actually my concern is better to correct all this at the same time,
Doctor, your
or
time is up.
to postpone open or EVAR. Thank you.